It's great to be here in Manchester because, as you, or some of you will have heard this morning, there are some amazing things happening here in this city and across the broader area of the Northwest. And it's no accident that we are having this event here in Manchester, where the Devo-Manc arrangements that I was up here signing with the local authorities, with the NHS, and with the Chancellor a few months ago are now well and truly kicking off. And in my view, they illustrate the kinds of opportunities in front of communities when they take control of the future. And I pay tribute to the fact that they are off to a running start with an offer to the public across Greater Manchester of 7-day access to GP services, of changes to improve the safety of emergency services 7 days a week, of improvements to public health, and today, an important new announcement around developing the science and technology base that Greater Manchester has to offer. So it's fantastic to be here in Manchester. It's fantastic to be here with you, who, as far as I can see, are the can-do, will-do, are-doing crowd of the National Health Service. And I want to thank Tim Kelsey and his team at NHS England for having put together this event again. So, some of you may have been away on your summer holidays at some point in the last month or 6 weeks. And as I came back to the office last week, I looked at the pile of stuff that was there and flicked through. And it reminded me a bit that if you've got kids, it's often your parents, your children's grandparents, who notice the differences about your children as they're growing up. And as I looked through some of this stuff, it reminded me that actually there is an enormous amount of change and improvement that has happened across the National Health Service over the last decade. And I think that puts wind in our sails for the challenges we now face. So in just thinking about what to share with you this morning, I want to argue that we've got to overcome 3 false choices in front of all of us who are health leaders, clinical professionals, patients, community groups. 3 false yes, no, this, that, either or options which we tend to lazily fall back into. The first is the idea that we have to choose between getting serious about health or getting serious about care. And so the research that I'm just going to share with you, all of which has been published while you may have been on your summer holiday, I think underlines the point that actually profound changes in health have the ability to have huge beneficial impacts, not just for the population, but also for the National Health Service itself. And so getting serious about health improvement, is part of how we make the National Health Service itself sustainable. So I'm sure you've clocked the fact that there has been a 44% reduction in cardiovascular disease deaths over the past decade. One consequence of that is that dementia prevalence has also fallen by a 1/5. New research, again, just published in Lancet Neurology. At the other end of the age spectrum, teenage pregnancy down by 41% since the late 90s. Health inequalities in this country narrowing. Over the course of a decade, a reduction of 2.5 years in the class gap in life expectancy in this country. So all of that represents what would have been patients having strokes, heart attacks, requiring care homes, turning up in A&E departments. And so when we talk about the health agenda for this country, we are also talking about the sustainability agenda for the National Health Service. But, of course, unfortunately, not everything is going in the right direction. And the reality is that when it comes to obesity, there are many causes for concern. If you go to the Diabetes UK stand in this hall, where you will see at least 2 people valiantly cycling, inverted commas, from Medway to Durham, and when they showed me that they'd got to Southwark, I wasn't quite sure whether they'd started in Durham or Medway, but unfortunately they've only started in Medway, so they're going to be here till at least tomorrow afternoon at their current rate of progress. But the fact is that when it comes to diabetes linked to obesity, we now know that we have 5 million people at risk of type 2 diabetes. And of course, the health service and the 1.3 million staff that we ourselves employ, we are as much a part of that phenomenon as we are a solution to it. And that's why today we are announcing the new focus on support for the health of our own employees, our frontline nurses, doctors, therapists, other staff, because I think it is increasingly obvious that if we don't look after the people who are themselves caring for patients, then not only will they not be in a position to care, we end up picking up a £2.5 billion sickness absence bill, and the quality of care itself is worse. We've known that for some time. It's time for the National Health Service to be the change that we want to see across this country. So 3 concrete things that we're doing today on employee health. First, we are working with a group of mental health, ambulance trusts, hospitals, primary care to demonstrate what 6 key active ingredients will mean for improved health of their employees. And then we want to roll that out beginning next year, starting with those workplaces, those employers with the highest sickness absence and some of the most challenging results in the annual staff survey. Secondly, we want to recognise the particular pressures bearing down on GPs. And the reality is that there has never been a more stressful or demanding time to be a general practitioner. We know that the sorts of programs to support GPs under pressure that have been tried in at least 4 different parts of the country have been shown to work, and so today we commit to rolling that out nationally from next year. And the third piece is, I think, something that strikes you every time you go on a hospital visit, either in your day job or visiting a relative, and that is that it is no good the NHS taking a stance on health and diet when our hospital foyers are stuffed full of junk food outlets, when staff working nights and weekends cannot access decent food. And so we have got to upgrade our own game. And of course, there's no magic wand that can be waved on that, but we are going to start beginning with the catering contractors, some of the PFI vendors, building on the success that hospitals have already had in tackling this problem. So more detail of that is available. I'm not going to flog that one any further this morning, but this represents, I think, an important first step in the NHS putting its own house in order and doing right by staff. And that's why we're doing so in partnership with the Royal College of GPs, the General Practitioners Committee, Unison, the staff side, NHS employers, and many others. So the health versus care false choice cannot be resolved purely by focusing on the work that is being done in the National Health Service. We have to take health seriously, and we have to start with NHS employees as well. But the reality, of course, is that most of the people working in the National Health Service are here to provide care for when people get sick. And that is rightly the main test that the people of this country apply in deciding whether the health service is working well. And here, the second of our 3 false choices, I think, is the suggestion that either we focus on the here and now and sort out the enormous pressures that there are, or we engage in the creative, imaginative reinvention of care that many of you are engaged with. That is a false choice. We have to do both. Thinking about the last 5 years, we all know that the health service has had considerable extra demand. We have seen 1.3 million more operations delivered, nearly 2 million more A&E visits, nearly 5 million more diagnostic tests a year over that 5-year period. And we also know that we've got substantial variation in the quality of care. When you think about what is happening in cancer care, for example, the Independent Cancer Task Force that recently reported has shown a very substantial change in difference in cancer referral rates. We know that the availability of investment in primary and community and social care has been squeezed relative to other parts of the system. Okay, so here are 2 numbers. Can anybody here tell me what those two numbers might be. Wild guess is perfectly acceptable. Okay, for the record, answer came there none. The box in the top left is what has happened to funding for general practitioner services since the economic downturn. And the box at the bottom right is what's happened in real terms to funding for general and acute secondary care services. And so I think it's no great surprise that we see continuing pressure compounding into the hospital system when you look at that clear disconnect in how we have used the resources at our disposal. And one of the places that shows up, of course, is A&E departments. So if you look at the difference in the number of inpatient bed days per 1,000 people across the country, adjusted for age, sex, and deprivation, you see this pretty startling spread. What that tells us is that there are some parts of the country that by having organised their care, by having invested appropriately, they are able to do a far better job of keeping people out of hospital. If we can get the end of the spectrum towards the 800 bed days per 1,000, nearer to the 560, 570 bed days per 1,000, we will have made a huge impact on the 22 billion efficiency challenge facing the National Health Service. And so this is not pie in the sky, this is the art of the possible, because you only need to go and talk to the GPs and the CCGs and the hospitals, the community services, and the right-hand end of that chart, find out what they're doing. So this is the art of the possible. Of course, we have to focus on pressures today. We have to continue to take substantial action to convert overspending on temporary agency staffing into permanent, flexible, well-paying jobs across hospitals, and trusts should not be waiting for Monitor or TDA to be issuing letters as to what that should look like. Trusts should be together with their colleagues and partners in different parts of the country, grappling and grabbing this by the horns and taking decisive action themselves. Again, it can be done. If you go talk to the chief executive of Wolverhampton Hospital Trust, he will tell you how they took action some while ago and have almost eliminated the use of unplanned agency staff. So this is in our gift. We now need to roll our sleeves up and do it. So yes, we've got to take account of health as well as care. Yes, we've got to think about tomorrow as well as today. And as we think about tomorrow, I'm hugely optimistic that the agenda that we collectively have set ourselves through the 5-year forward view is gathering real momentum. The fact is that when you think about the opportunities for cancer care improvement, as I say, we have still very substantial variation in the likelihood that people will be diagnosed when their cancers are at stage 1 or stage 2. And we're going to be hearing a lot over the next several days, weeks, about the importance of a consistent quality of care in hospitals 7 days a week. Let's also remember, though, that sorting out early diagnosis for cancer and improving cancer care in the way that the Cancer Task Force has sorted out could save us 30,000 lives by the end of the decade. So this is a huge opportunity, it's a huge moral imperative, and again, it can be done because parts of the country are already doing it. I think that, in turn, points to the fact that we've got a group of people around the health service who know what needs to be done, and in many cases are now getting on and doing it. I want to lend my personal support to the new women's leadership network that's being established across the National Health Service. I think about some of the most impressive leaders around the country. Many of them are women chief executives, leading clinicians, running patients groups, and without blighting their prospects, I think about people like Pauline Phillips, Katrina Percy, I think about Amanda Doyle, I think about Sam Jones at NHS England. There are an enormous wealth of talent, and of course, I think something like 80% of our workforce, our non-medical workforce in the National Health Service are women. So just as we have begun a conversation about improving opportunities for black and minority ethnic talent across the health service, removing the discrimination that stands in the way of advancement and tapping into the full benefit that we would gain as patients and communities from their talent, so too with the leadership that we need from senior women across the National Health Service. We've also, I think, got a huge body of goodwill to draw on from the front line of the NHS. I think my good friend Roy Lilly is going to be here, if not today, then tomorrow. And for anybody who doubts that our million-plus staff know what needs to be done, I say go look at Roy's Academy of Fabulous NHS Stuff website, which is just oozing with brilliant ideas that are being put into practice every day right across the country. If we can tap into that elixir of improvement and energy, then I am completely confident that the health service will be able to rise to the triple challenge that we face over the coming 5 years and beyond. And of course, we attempt to cash that out particularly through the Vanguard programme, which is this combination of local energy and national support. And that's the third of the false choices that I think we have to dispense with. The reality is that we've now got 37 Vanguards across the country, covering, depending on how you do the maths, between 5 and 10 million people. They're obviously in the early stages. They're 4 or 5 months old. We've got to be careful to give them the space to chart the triple integration that we know we need between physical and mental health, primary and specialist services, health and social care. But all the signs are that, given the right support, these are the folks who are going to be able to create the future. It's not the only thing we're doing, of course. We have got a range of other approaches to deploying innovation across the National Health Service, test beds, publishing today information on a range of other programs that people can choose to participate in, particularly those working in tech and devices. Within the next several days, Bruce Keogh and I will be publishing new proposals for the future of innovative cancer medicines in this country, which will link to something called the Accelerated Access Review, enabling us to offer the NHS as a place to test out drugs that appear promising but which don't yet have complete clarity about which patients they work for and work for best. So my conclusion, I think, is that we stand at a moment in the health service where either we can go down a series of blind alleys and dead ends. We can focus purely on the here and now, which we, of course, have to do. We can ignore our long-term prospects. We can focus entirely on the way care is delivered while ignoring the big gains that we can also make in population health. And we can get ourselves tied up in knots about what should be done locally, what should be done nationally, when the reality is we need action on all fronts. So recognizing that times are tight and people face considerable challenges, nevertheless, I believe we should be self-confident about the future, and if we, in any way, the people here are representative of the 1.3 million people and the broader communities the health service engages with, then we can feel very good about what the next 3, 4, 5 years will bring. Thanks so much.
Thank you very much indeed. Just before we go to questions, I just want to put a bit more detail on the 3 areas, the 3 new things you're announcing today. The support, you'll need that one, the support for the health of your own employees, support for GPs, and you didn't use the word crackdown, but I'm imagining the junk food outlets and hospital food and that kind of thing. On the health of your own employees, how will you measure that? Are you imagining that, apart from sick days, that there is going to be some kind of measure of the health of employees in any given hospital, for example, or CCG?
So I think there are several ways into that. One is that we already offer, as a country, health checks for people aged over 40, but they're not offered to NHS staff at their place of work, which is kind of paradoxical, given we've actually got most of the wherewithal to make that a reality. We obviously, as you say, will be able to track this through sickness absence, and there are big differences in sickness absence rates across the country. And we will be able to clock it through the results of the NHS annual staff survey, which provides, I think, very good leading indicators as to whether the kinds of work environment that people are facing are positive, healthy work environments, or they are work environments where people...
It will be measured in order for you to know. Right.
Absolutely.
And why do you think that the NHS has a worse rate of staff sickness compared to the economy as a whole?
Well, I think first of all, the jobs that most frontline health professionals do are as demanding, probably more so, than just about any other walk of life. Secondly, I think the altruism gene runs strong in the National Health Service, and so people always put other people before themselves and their own health, but actually, if we don't look after the people providing the care, they're not going to be able to do that well. And thirdly, the reality is that in some places, we need leadership that listens, takes ideas seriously, and creates the kind of environment where people feel that they can flourish in their careers. And we have big differences across the country and the extent to which that's true.
But given that it's sort of the national average is about 4 sick days per annum, and in the NHS it's something like 14 in some places, what are you aiming for? That the NHS should mirror the national average?
Well, we aim to cut it by as much as we can. Obviously, if you're involved in a physically demanding job, then your sickness absence often tends to be higher, but we can design out, there are 2 principal causes of sickness absence in the National Health Service: musculoskeletal problems and stress and mental health problems. And so some of that can be designed out by the way we arrange work. Some of that, if we get people support they need early on, physio, access to mental health services that have been shown to work in different parts of the country, that will have an impact.
Okay. Support for GPs. Can you give a bit more detail on what you mean by that?
Yes, so Claire Gerarda was on the Today programme this morning describing this. Claire runs one of the programmes already up and running in London and I think covering Brighton as well. And they offer a confidential support programme looking after GPs with at risk of burnout, frankly. And there are other examples like that around the country, but it's not a national offer. It's something that GPs have been saying for some time they need, and now we're going to do it.
Okay. And lastly, the focus on food in hospitals, whether food provided to patients or staff or food sold. Has it got a bit out of control with the amount of junk food that you can? I mean, you have Burger Kings in hospitals, for example. Is this an acknowledgement that something went wrong in the way that the outlets that were given access to hospital premises were looked at?
I suppose yes is the answer to that question, in that we know that availability and affordability makes a huge difference to what people end up eating. And so if all that's available is kind of food that is not consistent with the kind of lifestyles that people want to lead, then of course that's what people end up consuming. So, it's a complex question. There are several hospitals now which have either terminated those franchises or have said to those vendors, if you're going to carry on, then you've got to offer a different range of options as well. And, I'm not going to name the particular hospital because that would be unfair, but a hospital in the West Midlands that I was wandering around with nurses and doctors a few weeks ago, it seemed about every 200 yards down a very long corridor, there was another place selling chips.
And plenty of vending machines. Now, you've talked already about, your views on fizzy drinks, particularly for children. Could you not ban vending machines in hospitals that sell sugary drinks?
Well, that is something that we're obviously going to be working with individual trusts on. I don't think you necessarily have to have bans, but you, I think, do want to make sure that people have got easy, better alternatives.
Would you rather they weren't there?
I would rather people had easy, better, affordable alternatives.
All right. Okay. Right. Your questions. If you could raise your hands and we'll get microphones to you. Right. I think we've only got 2 microphones in the room. Could we get one to the lady in the pink in the middle of that row? And where is the second microphone?
It might be in my hand.
Well, I'm hoping that we're not that cash-strapped. That
we're sweating the asset here.
If you go first, and we'll try and get a second one over to this side shortly. Yes, the lady over there. If you could just stand up and say who you are. Sorry, who did the mic? Did the microphone not go to who? Oh. Yes, if you could, yes, go ahead. If you could say who you are and then go ahead with your question.
Hello, Simon. My name's Heather Henry. I'm the co-vice chair of the NHS Alliance, and I'm a practicing Queen's nurse. Thank you for your presentation and the announcements this morning around staff health and well-being. I just wanted to look at this from an asset-based perspective. I practice asset-based approaches in disadvantaged communities. And some of the things that I see in disadvantaged communities, I also see in staff. You'll notice from the Whitehall studies, for example, that Sir Michael Marmot did a few years ago of British civil servants, that those at the lower echelons felt more stress and experienced more cardiovascular problems than those at the top level. I know from listening to fellow nurses that sometimes they feel that they're more like deficits than assets. And that's not universal across NHS organisations. But I'm just wondering how we can enable nurses and other healthcare professionals in particular to look at how they can feel more in control of their lives, feel more listened to, because I do worry that we are looking at treating the effects on their health when actually we could encourage employers to concentrate more on the causes of their stress.
Do you mean shifts, work pattern, that kind of thing, as well as the actual what they're doing in the course of their shift?
All of those things. I think it's important that healthcare staff feel listened to and feel more in control of their working lives.
Thank you very much. We're going to take a question here, and someone else had there, and can we, someone else over that side of the room can have the third question. Yes, sir, your question.
Thank you. I'm Dr. Kailash Chand. I'm the deputy chair of the BMA as well. Simon, I must congratulate you that for the first time, I think you have moved from so-called health care and care to really looking to the health of the nation. And that's very, very important. We congratulate you on that. But the real issue you have is that if you're looking at the total health, yes, we agree that in headlines, NHS budget has been sustained or even tiny bit improved. The real problem being the social budget, which been cut like anything. And until unless social budget is also matched with NHS budget, you can't achieve what you're really looking for. And my second point is, you have talked about the sickness as far as the NHS family is concerned. You've talked about so many issues, but I think the most important thing here is the bullying, the burnout, and the stress the people have because of lack of resources. You're expecting, for example, GPs to work more, and you yourself said with much less.
All right.
So what are you going to do about that?
Thank you. So, two similar questions, so a good place to start.
So yes, I think they both make the same point, and it's the correct point, which is that it is not just about the things that we've been talking about, it's also about the extent to which teams of health professionals frontline feel able to control the workload, influence the direction that their services are developing in. And I mean, the good news is that, the bad news is that there's a big difference in the experience across the health service, perhaps not surprising for an organisation as large as this. The good news is you can go a few miles from here to Wrightington, Wigan and Lee NHS Trust in Wigan, as I recently did, and I think you will find there an organisation that absolutely has nailed the kind of questions that you are addressing.
How?
How? By virtue of giving staff more control, by listening more carefully to what patients are saying, and by changing the culture such that the issues around that Kailash raises around bullying or discrimination have, I think, been very successfully tackled there. They've got a fantastic leadership team, very good medical director, known to many. Kailash asked two other points, though, which I might just touch on. One is the spillover impact on the health service of pressures in social care and more broadly, and I agree with that. When we said in the NHS 5-year forward view that we, over the next 5 years, needed a minimum level of resourcing, that was on the basis that the offer from social care was sustained, that action was taken on the broader determinants of health, including prevention, and the reality is that the NHS is not an island. We are embedded in our communities in every part of the country, and what happens there has a huge impact on the ask that is placed on the National Health Service.
Okay, thank you. Could we take a question from the gentleman there? Yes, he's got the microphone. And then, and can we get the microphone to this gentleman here and then that lady there. Okay, go ahead, sir.
I'm Mr. Sibbons, a member of the public. If I want to, I want to look at one of the roles.
Could you raise the microphone a bit, sir? Yes.
Is that better?
Yeah.
Thank you. I want to look at one of the roles of patients in the public. Yes, we have a very firm role in terms of looking after our health, etc., etc. What I want to look at is the other side, which is very important. If I want to vote in the parish council, the local council, for my MP, if I want to take part in the referendum that's upcoming, I automatically get a vote because I'm on the register. If I want to stand or vote for the local, for a governor on the trust of my local hospital that is coterminous with my parliamentary constituency, I have to jump through two barriers. I have to become a member of the trust as well as being a registered voter. This has resulted in my area with a minute number of people being involved. Now, surely it's time that we got rid of this.
Okay.
Then we come to an even worse situation on the CCGs, where they have two lay directors. We, the patients and public, don't even get a vote on that.
Okay.
The
And you would like that
CCGs
vote?
decide
I'm sorry,
who
I'm
they're going
going
to
to
have.
have to just get
What can be
to
done
the
about
point here.
that,
So
please?
you'd like a greater say, essentially, in both the CCGs and the hospital trust. Thank you. If we could come to, and then lady over there for the third question.
Thank you. Hi, Simon. Nicholas Peat, general practitioner, also medical advisor to doctors.net, which is the largest network of doctors in the UK with over 200,000 members. Simon, what can you tell me in terms of me being able to reassure the members about how you intend to increase the number of GPs who are being recruited into practice, which in particular the East Midlands and also the North East of this country is as low as 50%. If you want to acquire another 5,000 GPs by 2020, how are you providing that support to the recruiters?
Thank you. Yes.
Hello, Simon. I'm Edna Robinson. I'm chairman of Liverpool Women's Hospital, but I'm also chairman of the Big Life group of companies and charities, and I'm here today with my team. And we are very proud now to be NHS providers. We put money into the health service through our charitable funds to start up mental health out of our services, getting people back to work through hard-to-reach employment initiatives. We are outside the club of the NHS. We've got a workforce who are now NHS employees who are incredibly proud to be in this club. But looking at the programme, it's the usual suspects, it's the same people having the same conversations. My challenge to you is, how can these new young people who are coming into the health service, who don't necessarily want to work in a trust or in a traditional way, how can you help us to get into this conversation about changing healthcare for the future?
Right.
We are going at risk to get ourselves into this club. Please invite us to your table.
Thank you.
Great. Well, Edna, you're welcome, and it's great to see you storming the barricades. The reality, of course, is that the health service has for years relied on its partnership, which in some cases has been formalised and of mutual benefit, and in other cases has been pretty hit and miss with the voluntary sector and with other organisations. We are kind of nested in that, and if you just go back to, whether it be the Red Cross or the, League of Friends or Macmillan Cancer or any of the big national organisations, but also the huge ecosystem that exists in each community of smaller voluntary organisations. And I think one of the interesting things, actually, that this meeting represents is that as a result of, apart from anything else, technology, new means of social interaction, communication, and so on, a lot of those quite formal boundaries are beginning to dissolve. And one of the big asks of the vanguards is to show how they are engaging with the full range of community assets and organisations in their areas. And I think, the reality is that that is not something that has always been the kind of reflex mode of operation across the National Health Service. But increasingly, I think interventions like yours will change the mood music on that. And so fully agree with your point and welcome what you're doing. And let's chat straight after.
Point about GP recruitment, and then the one about patients having a say in the boards.
Yes, so on Nicholas's point, I mean, frankly, I think we need as many extra GPs as we can get over the course of the next 5 years and probably beyond. I've previously gone on record and said that it was unfortunate that the rate of increase in hospital consultants has been 3 times faster than the rate of increase in GPs over the course of the last decade. Not that we don't need the hospital consultants, we do, but that's a pretty substantial imbalance, and that partly shows up in that difference between the slight reduction in spending in GP services versus the increase in other parts of the pie. So what are we doing about it? Well, Health Education England have responsibility for training increased numbers of GPs. As you say, although the numbers going into GP training have roughly speaking been flat, they've not expanded in the last several years at the rate that the extra posts have expanded. And we do have an issue in some parts of the country where it is much harder to fill those slots, and East Midlands is one of them. On the other hand, in places like London, actually the GP training scheme is kind of something like, 97, 98% subscribed. So we are looking at a whole range of things to boost the attractiveness of general practice, but as well as new trainees, we've also got to support people who are currently in general practice and think seriously about new ways of getting people to come back, particularly if they've left to have a family. And so part of the reason for majoring on support for GPs today is precisely to try and reduce the rate at which, for stress or burnout, people are otherwise contemplating leaving the profession. So it's an all-of-the-above approach, but it's not just GPs. Obviously, it's also community nurses. We've just launched a program to part-fund pharmacists in general practice as well, recognising that, strangely enough, perhaps we've got a apparent surplus in the number of pharmacists coming out of training, and so that's a great opportunity to put them alongside GPs, nurses and others.
But you could attract more GPs and have exactly the same regional differences, couldn't you, where it's still as difficult to get a GP to work in the East Midlands because all the new ones want to work in London. So how could you incentivise GPs to work in parts of the country?
Well, so we are looking at that. We're looking at different place-based incentives. There's a debate about the extent to which they do or they don't work. There is also, frankly, an issue about making sure that as doctors are coming out of medical schools in different parts of the country, those medical schools are sending a very strong signal about the value, the professional status, the stimulation, the flexibility that a career in general practice brings. And there are great examples. University of Birmingham Medical School, fantastic history of promoting general practice, for example. We need that across the board. But I'm not saying it's the fault of medical schools. I'm just saying that there is a big difference in the proportion of new doctors who choose to go into general practice in different medical schools around the country.
Okay, and the point the gentleman there made about being able to have a more direct say in appointments to boards and CCGs.
Yes. Well, I think we are going to find a whole range of new ways in which the public and patients can shape the destiny of their local National Health Service, but I don't think we're headed to a position where we have direct elections for CCGs. The reality is that that's not something that any of the main national political parties are currently proposing. Our elective accountability exists through the decisions we make at the ballot box for Parliament and increasingly for local authorities too.
Okay, thank you. Could we go to the lady there, and then can we get a microphone to the gentleman there with his hand up near the back? And then we'll decide. Yes, go ahead.
Caroline Price from Pulse magazine. I've got a specific question about the new occupational health service for GPs at risk of burnout. Could you explain, will this be fully funded by NHS England, and how much money are you going to put into it? Also, will it cover all GP practice staff?
It's going to be funded by NHS England and CCGs, which CCGs are already partly funding some of these schemes. What there hasn't been is a national set of standards for the offer that has to be made available. That's what we're doing, and that's what we're going to back with cash from NHS England as well as CCGs. In the first instance, the focus is on GPs, building on the particular pressures that they're experiencing. Obviously, as I've said in the first part of the announcement today, we want to extend the offer to all NHS staff, but the particular targeting of the occupational health service for the second element is GPs.
Okay. Could we get that microphone to the lady in the front row? And sir, go ahead.
Hello, my name is Avi Prasad. I'm a GP from Leicester, the East Midland. We've heard a lot about why we can't get GPs. The 2 points, very quick ones. The first, when will we, as a nation, have the courage to say we can't meet the expectations of what we, and politicians particularly, keep asking that we will have a right to? 7 days service from GPs when we have difficulty delivering 5 days is an unreal, surreal expectation. So having the courage to tell the voters that this is the money we've got and this is what we can provide, we can't provide everything. Having an adult and really an honest conversation. The second thing is litigation. Most clinicians are worried about litigations most of the time, which leads to different kind of medical practice. Having a kind of litigation process by which nationally, I'm not saying to indemnify, but really make it easier so that if an error has occurred, which every clinician will make, it becomes a learning experience if it's an honest error rather than crucifixion.
Yeah. Thank you. Yes, your question.
Hello, my name is Mandy Ridzenko. I'm on the People's Panel and I'm a carer for my son. The 5-year forward view talks about helping NHS staff who are carers and who are experts by experience to enable them to work. That kind of makes me feel excluded as a carer because I don't work for the NHS, but I do want to work. I have extreme difficulty getting work. Twice I have had to give up a job of a permanent contract because the employer was totally unsympathetic to my situation. I now have to rely on 0 hours contracts. And the fact that I can't go to work properly really affects my mental health. And I'm not the only one in that situation. Carers really need your help with the 5-year forward view to help our health, to help the health of the people we're looking after. Otherwise, we're just going to burn out, the same as the NHS staff. So I'd like to know what the 5-year forward view can do to help us.
Yes, thank you. Well, first of all, I think there are something like 5.5 million people in your situation across this country. So this is a huge issue. And I think it's something like 1.4 million people who are full-time unpaid carers, providing more than 50 hours of care a week. So in a way, for everybody in the room who works in a paid job with the National Health Service, think that for every one of you, there's somebody else who's the unpaid carer who is actually part of the health and care fabric of this country. But it does, as you say, place enormous pressures on carers, often unfairly. So my colleague Jane Cummings, the Chief Nursing Officer, together with Carers UK and a number of the other national organisations, last year we published a series of actions that we committed to undertaking and have just, I think, published our update on the work that's gone on over the past year. But I'm not going to give you a glib answer. I mean, the reality is there is no some kind of easy thing that I can just sit here and say to you requires doing. But I do think that the argument is increasingly being heard about that huge, indispensable, but often invisible army of unpaid carers.
And the point the gentleman made about more honesty with the public and perhaps with politicians about 7-day working.
Yeah, so I don't know the extent to which Bruce got asked about 7-day a moment ago. Not at all. So there we are. I'll be Bruce's spokesperson on this one. The reality, I think, is that when it comes to the debate we're having on 7-day services, 3 separate problems have all got kind of mixed into one. And I think we've got to unpick what are the 3 things that the health service is needing to face up to. And then it's going to be different answers for each of those 3. The first is that there is now, I think, indisputable evidence that the excess mortality for patients treated on a weekend is higher than that on a weekday. And Bruce and colleagues have led the publication of those data, peer-reviewed, further data to come. So the question is, what are we going to do about that? I think the lead that Bruce and the Academy of Medical Royal Colleges, the Royal College of Physicians, the medical profession as a whole has set in saying we've got to take a hard look at whether there are changes to the way in which we organise services that would help us tackle that. That is something that we've clearly got to do. And here in Greater Manchester, the recent decision of the hospitals and the CCGs to ensure that patients were getting emergency surgery at hospitals with the full 7-day-a-week backup is precisely the kind of approach that we need more generally. The second of the three problems is the fact that on evenings and weekends, out of hospital, it can be pretty confusing for the public to work out where they should be going for their care at times of an urgent or emergency problem. Obviously, the A&E department is straightforward, but GP out of hours, 111 services, walk-in services, minor injuries, it's a right old alphabet soup. And so the second thing we've got to get right is we've got to streamline the offer for the public for what the urgent and emergency care out of hours services are that the NHS provides. And work that Keith Willett, Professor Keith Willett is doing precisely that. The third of the three, which perhaps is the one you're getting at, is the question of the extent to which we ought to try and make available to the public routine access to GP services evenings or weekends. And the reality, of course, is that actually in many parts of the country that is already happening, not necessarily in every practice every week, but on a rota system, Thursday evenings, Saturday mornings. And I think what we sometimes forget is that, yes, we have this debate, this trade-off about the availability of staff to do this, but if you're a manual worker on an hourly wage who cannot get time off work or who will forfeit your earnings if you have to take a morning off in the weekday to go wait in a GP surgery, actually that can produce people putting off needed care. And if we're serious about tackling inequalities, we've got to be serious about thinking about how we make these services available more generally. So it's not going to be something done in every surgery every weekend, but again, the example that Greater Manchester has set with their proposition for 7-day access by the end of this year is an example I think people should take a careful look at.
When the Health Secretary raised this a few months ago, and I think at that time he was talking particularly about hospitals, and he was bombarded on social media with pictures of NHS staff, I'm in work, Jeremy. Whose side were you on?
Well, I'm on the side of patients and staff.
But between the two of them, I mean, are there NHS staff who are either in denial or not open enough to the problems you've outlined?
Most nurses already work shifts, weekends. Most doctors in training
how about
do
the
that.
consultants?
Many consultants do that as well. We don't need every consultant in every specialty to be providing planned care on a Sunday. What we do need, and this is what the Academy of Medical Royal Colleges have said, is we need access to senior consultants in clinically critical parts of hospitals through the working week, and we need diagnostic backup to be available for them, and we need other parts of the hospital that relate. That's how we will tackle the excess mortality challenge.
All right, we're going to let you go in literally a minute. I'm going to take one final question here in the second row. Can you do your question in 30 seconds, please?
I'm James Hallinan from Cambridge University Hospitals Trust. Simon, I was very interested to see your announcement about making the UK a testbed for innovative cancer therapies. In Cambridge, of course, along with our colleagues in academia and industry, we've been at the forefront of developing new therapeutics, not just in cancer, but across all indications. I'd be interested to hear what practical support is going to come to trusts like ours that are at the forefront of doing this sort of thing, but are constrained by capacity, and also what reassurance you can give industry who are concerned about what reimbursement is going to be like for new and often necessarily expensive therapies.
Thank you.
Yes, well, James, we will be answering that question comprehensively in the next several days. But first up, obviously, in Cambridgeshire, you've got a fantastic academic health sciences infrastructure that links the university with the medical school, with the hospital, with primary care, with the biosciences sector, the new Astra building going up just next to Addenbrooke. So you've got a fantastic foundation to build on. We're never going to be the country that pays the highest prices for things, and nor should we aim to be. We should be the country that makes it easiest for people with high-value innovations to come and put them into practice and, in return, get a fair reimbursement. What we want to do in respect of cancer drugs is make sure that we have, in addition to the usual NICE appraisal processes where NICE can say yes or no, they can say maybe we should test this particular product further to find out whether it's as good as we think it might be. And that's the proposition that we will be advancing.
All right. Thank you very much. I'd like to apologise to anyone whose question I didn't get to, and I know that is a lot of people. So thank you to everyone who contributed to this, and thank you very much, Simon Stevens, for taking all of that on board. Thank you.